Okay, here we go. I'm going to try and keep this as brief as possible. I offered to record a video to introduce students to advanced integrative therapy as a novel somatic treatment modality for trauma. So instead of just telling you about it, I'm going to very briefly speak a little bit about the proposed mechanisms of action, how it works, and hopefully get you interested in something that not very many people know about. First of all, my name is Elizabeth Pace. I am a AIT teacher, supervisor, researcher. I'm also a college professor. I work in the counseling graduate program at Loyola University in New Orleans, Louisiana, in the US. And I spend a lot of time talking about AIT because once I found it as an intervention to utilize with clients and I found the results to be so profound, I was really surprised that no one else knew about it. And I've got the kind of personality that I want everyone else to like what I like. And so you don't have to like it, but hopefully you'll leave this very brief talk just knowing a little bit more about it. Okay. Um, so we're operating under the framework from somatic trauma therapies that there's a truth that someone has underneath their trauma, that the coping strategies that they formed as a result of experiencing chronic stress or trauma is not the real them, but that there's something underneath. And so, a really wonderful book about racialized trauma, at least in the United States, is called My Grandmother's Hands. And he mentions often the intergenerational passing down of trauma, that it isn't just something that originated with the client that's sitting in front of you in the office. Just setting a timer for myself so I can move fast. And then Dr. Clinton, who is the woman who synthesized advanced integrative therapy, she was originally a Jungian analyst. And so she draws deeply from the psychodynamic perspective that the past is always present until we become conscious of and heal the past. And a lot of people will say, "Oh, I don't have any trauma because I'm a high functioning member of this society." And I share this slide whenever I give a talk about trauma because everybody's got a nervous system, which means that everyone has to manage anxiety. This is my beloved dog, Rocky. He's a rescue. And one of the ways he likes to manage his anxiety is by starting a dog fight in the neighborhood before the fight can come to him. So I always have to remind him, like, hey, we don't do it that way. You can just calm down. Something my dog trainer has taught me is I take a hand and I run it from the top of his head down to this tip of his tail to help soothe his nervous system when he's getting activated. So what makes pervasive and chronic stress so very hard to treat? And in 1988, Dr. Judith Herman is who synthesized this new diagnosis, complex post-traumatic stress. At least in the US, we're still using the Diagnostic and Statistical Manual of Mental Disorders, which does not um, identify that CPTSD is a diagnosis. But the ICD-10, the International Whoops, nope. The ICD-10, the name of that is not going to be, it's like the classification of diseases. That's a long shot. They are starting to say that complex post-traumatic stress is its own separate diagnosis because it has such a challenging symptom cluster. So the symptoms that show up for someone with complex post-traumatic stress, behavioral difficulties, impulsivity, aggressiveness, sexual acting out. I see a lot of clients in my private practice who are there for sex addictions and wouldn't describe themselves as being highly traumatized individuals. But once we get to a certain depth and find out what's going on, the present day behavior makes a lot more sense for them. But behavioral difficulties can lead to misdiagnosis, like a conduct disorder in an adolescent who's actually got something really painful and frightening going on at home, but they don't have words to talk about it, so they're acting out. Emotional difficulty, affect lability, the roller coaster of emotions for these clients, rage, depression, panic, shame, and despair. These clients have a really hard time sticking to a treatment theme because life is so chaotic for them. But these are also clients who get misdiagnosed with borderline personality disorder. And to you guys who are grad students, I will say this. I would never say this to a client, but a colleague of mine once said that sometimes we say that person's acting really borderline when what's happening is that they have started to push our buttons and there's something about them that we don't like and it's making us uncomfortable. Because the symptomology of complex post-traumatic stress and borderline personality disorder, if you put them up in front of each other as a comparison, we're almost looking at exactly the same thing. Cognitive difficulties, dissociation, pathological changes in personal identity. This is why talk therapy can be so challenging, is because the front-facing ego, the one that takes them to the grocery store and signs the checks and interacts at work, is who can answer the questions, but the certain depth of what they've split off, they're not letting you have access to, and they're not conscious of that. It's not intentional. And then interpersonal difficulties, chaotic personal relationships, including very chaotic therapeutic relationships. These will be clients who either overly attach or fire their therapists because of how hurt and threatened they feel. And then somatization, of course, resulting in many visits to medical practitioners and having those doctors go, nothing's wrong with you. It must be in your head, which is so destabilizing and painful. And often for our clients, it's a recreation of some of their past experiences in their childhood. Nothing's wrong with you. It's all in your head. That we believe that trauma is stored in the body, so that more research is being done on the effects of chronic stress on the body, chronic fatigue, gastrointestinal issues, inflammation, and then the looping effect of thinking about your symptoms, activating your immune system, getting your symptoms, and then being in a figure eight looping effect between your insula, your amygdala, and your immune system. So painful. I'm going to really fly through this one. Additional symptoms: feeling very angry or distrustful towards the world, feeling permanently damaged or worthless. That's why therapy can be so hard. Dissociative symptoms: depersonalization or derealization. That's detachment from trauma, but also from the world. Feeling like they are utterly alone, even if they're in a room full of people. Why is talk therapy sometimes ineffective? Yes, I made this meme myself. Maybe you guys aren't going to get the joke in Queensland, but I hope so. The Western medical model is part of what's re-traumatizing. The problem is individual or in here. It's a me problem. It couldn't be a systems problem. That's pathologizing, sometimes very traumatic. It assumes individual single event trauma and symptoms instead of what happened to you is real. And so then if a client doesn't know that they are dissociative, failing at talk therapy can trigger shame. And then the psychodynamic or intergenerational trauma model, which is what AIT pulls from, is that it didn't start with you. We say that to our clients. Where did you learn this? Who taught you about how to be a person? Where did you learn this? So also, if you're hearing me talk, there's a lot of similarities to the psychodynamic or intergenerational trauma model and attachment theory. So when our clients wire to survive early experiences, that behavior made perfect sense in the setting, but now these coping strategies are extremely harmful and not helpful. I got this straight out of my grandmother's hands. The midbrain is a gatekeeper of sensory information. So if information comes in and someone has an overactive limbic system, immediately upon entry of sensory information, the hippocampus, the memory center of the brain, goes, oh, we've been through this before, and I know exactly what to do. Shoots information, this is threatening, over to the amygdala, and bang, resources shift from higher order cognitive computational capacity, where all of those resources exist for how to talk about your feelings, or that, your partner is not your dad, whatever it is. And to use a non-clinical term, clients get poo brain. They're all of a sudden so flooded with the threat response that they can't get into the resources that we try to give them in talk therapy because they're too activated. So we need something different. I'm happy to show this slide deck to you. I'm really trying to just fly through it. In the parasympathetic nervous system, or rest and digest, this allows a functioning system to repair itself, get restorative rest. We have optimal immune system functioning, and that messages from the body, pain, can be felt and attended to. I heard someone say once on a podcast that pain is like prayer. It's your body's attempt to get help from a part of you that has more resources and capacity to do that. But if we don't receive the messages from the body, they get louder and louder. And then sympathetic nervous system responds to actively threatening situations, a yelling spouse, getting cut off in traffic. But it also responds to imagined threat situations. I'm driving into work and I know I have to ask my boss for a raise and I'm terrified. And my nervous system is starting to get me into the threat response because it is perceiving what's about to happen as dangerous. Cannot tell the difference between an imagined threat response, a real threat, and Homo sapiens get something like 50 of these threat cues per day. So we're all just swimming in cortisol, lactic acid, norepinephrine, these threat chemicals that are for running away from predation. We're not meant to be swimming in them all day, every day. The biopsychosocial spiritual perspective, there's a psychological dimension, a biological dimension, and a social dimension, but also a spiritual dimension. And that we in AIT believe that reconnecting with one's deepest, wisest self could be described as a spiritual experience. Not, some sort of higher heavenly power necessarily, but to be able to hear your intuition and act in your own highest wisdom. So the proposed mechanisms of action for AIT, its intervention is extremely simple. You put a stationary hand somewhere on your body, and then you use your movement hand to run through the dominant energy centers in your body. Crown, forehead, chin, throat, heart center, left heart, right heart, solar plexus, belly button, pelvis in the center where your hip bones would meet, left hip crease, right hip crease, and your root, so the base of your tailbone. What this does is bring focused attention away from the head, where we're thinking all the time, down into the body, where we have a deeper level of wisdom. Very similar to tapping at meridians. EFT is what Dr. Stapleton is a master in and master researcher. Don't let her tell you otherwise. And that tapping or hand movement in this way is bilateral stimulation, but it's up and down, top, bottom, or bottom up instead of side to side. So if any of you guys are familiar right now with EMDR, the proposed mechanism of action is the same: bilateral stimulation, allowing for adaptive integrative processing between your right temporal lobe, which is all of the sense memories that come with trauma, and your left temporal lobe, which is where all of your functional, computational, healthy adult resources are. When I have a bad day, I call a friend instead of, go to a bar and drink 7 shots of whiskey. And there are nerve ganglia at each of these energy centers. And so long before there were researchers or college students, universities that were doing study, there was like a basic human wisdom that this had a soothing effect on the nervous system, which is moving your hand midline, or tapping, drumming, dancing. These are all forms of bilateral stimulation. And so just quoting one of the studies that I used for this talk, chakras are a basic concept of yoga, which is science, right? Like yoga isn't just relaxation in a studio somewhere, but are typically ignored by scientific research on yoga, probably because the descriptions of chakras can appear like a fanciful mythology. I have a hard time saying the word chakras. I prefer to say energy centers. Affect labeling. So research shows that when you put feelings into words, you are using a higher order part of your brain. You're tapping in your cerebral cortex to say, oh, this is sadness. This is what sadness feels like. This is an emotion. And your limbic system can go, oh, okay, feeling, not danger. We go, yeah, that's right. It's just a feeling, not danger. And that affect labeling disrupts the transmission of the threat response to the amygdala. So fMRI research shows that affect labeling disrupts that amygdala activity in response to affective stimuli. It cues the relaxation response. So we go, oh, okay, it's just a feeling. I'm not in danger right now. Because remember, your nervous system can't tell the difference between imagined threats and getting cut off in traffic. Taking a deep breath, utilizing diaphragmatic breathing, it cues the relaxation response, and breathing in the presence of an affective stimulus in the office with our clients proves to the nervous system, so it's having a corrective emotional experience, that what they're going through feels difficult but isn't dangerous. And memory reconsolidation, retrieval competition, reactivating old memories, engaging in new emotional experiences that are incorporated into those reactivated memories. Because if you think about a core memory that you have, what got stored in your mind that you're retrieving is not exactly what happened at that time. And every time we pull up a memory, it's a little bit different than the last time. So there's a certain plasticity to memories. Thereby, when we pull it up, we can reinforce a new memory structure, add in resourcing. All I needed when I was 4 was someone to tell me that it was okay to be sad, right? And so let me just add in now, when I have my stationary hand and I'm moving it through the energy centers, we're also pairing that with a treatment phrase. So when I was 4, I fell off the swing and broke my arm. When I was 4, I fell off the swing and broke my arm. So rather than just coming from the framework of recalling that or talking about it, I'm feeling the emotions and sensations that arise when I retrieve that memory, and then doing that in the presence of my healthy adult self allows me to desensitize and reprocess the emotional charge with that memory that's stored in my body. And that psychotherapy creates new memories that compete with existing ones. We want AIT to be something that people take away with them that they can use at home. And we call that quick AIT. You can create your own phrase. All my nervousness about asking my boss for this raise. And then you put a hand somewhere in your body where you're feeling the sensation of nervousness. You do a couple of rounds of that. And you can raise your set point of, okay, this is nervousness, but it's not something that I'm currently in danger as a result of. So what somatic body-based therapies like AIT do is, instead of going top down, right? We're not going to think about things. We're going from the bottom up. We're letting whatever arises have meaning and import and get attention. So this is, in a way, euphemistically, like being the healthy adult, perhaps, that you might have needed when you were younger. You are becoming the self energy that internal family systems talks about. And so I think about talking to traumatized parts a lot like how you've got to talk to children. We don't reason with them first, right? If my child has just spilled a gallon of milk in my kitchen, I don't go, you know better than to pick that up. I could do that, right? But that's just going to scare her. If I get down on her level and go, okay, hey, we have a kitchen floor covered in milk. Let's clean it up. You're okay. You're not in trouble. Looks like you just made a mistake. No big deal. And it's not what I'm telling her, but what she can feel, right? Coming off of my body, which is, I'm not stressed out by this. So that way you don't have to be stressed out by this. Then we can relate, right? Everybody makes mistakes. That's a totally normal thing to do. Everybody has tried to bite off more than they can chew. And then later, when everything has calmed down and the kitchen floor is milk-free, I can say, hey, remember, that's why we say ask for help when you need someone to pour you a glass of milk, because your hands are just too little bitty. But we have to start at the bottom, not at the top. And that our systems do want to grow these set points. We want to be our aspirational selves, good partners, friends, parents, students, therapists, etc. And so practicing soothing the nervous system in a safe relational environment and inviting our clients to do that outside of the therapeutic relationship in their everyday life, practicing orienting to time and place where you are in your body and all we are doing is going back in time to release something that is challenging. Doing orientation as a practice transforms into being oriented, meaning that improvisation is the goal, right? Like what we do in AIT is a little more on the manualized side, which is really nice for new professionals as well. It's great AIT practice to have an open manual in front of you and be just checking what you're there to work on that day. And not to bury the lead, but one of the coolest and best things about AIT is that we also use kinesiology style manual muscle testing. So when we talk about assessing anxious boy, when we talk about accessing the body's wisdom, we use kinesiology style manual muscle testing to do that. And Dr. Ann Jensen, who lives in Australia and is a brilliant woman, did her entire doctorate of philosophy at Oxford University about a decade ago on kinesiology style manual muscle testing. And what it is testing muscle strength or weakness and the presence of a statement. And if the body perceives that statement as being false, the muscles go weak. And if the body perceives or senses that statement as being strong, then the muscles stay strong and you can't put pressure on the arm. And it's incredible. So what it also allows me to do between muscle testing, which allows me to get kind of bypass that protective ego or intellect down into the body's wisdom. And then with a manualized list, what we start out doing in AIT is something called the Alliance Agreement, which is treating blocking beliefs. Things like, it's not safe to be healed. I'll be deprived if I'm healed. I can't bear or survive all of my emotions. And that these are so common, such common blocks for treatment, that we treat that first. If you're interested in learning more about AIT, I have a website that's called fullcircleceu.com. And I'll add something at the end of the video with just where are the places you can find a little bit more information about it. I often describe AIT to my clients like EMDR's weird cousin. Like she lives in a camper van, does Reiki therapy, dances in the moonlight, and bathes her crystals in certain phases of the moon. And honestly, I don't care because it works incredibly well. I've also been doing research on AIT for about 5 years now, and the research is continuing to show, even though it's at very early stages of conducting it, that AIT works. We've done a randomized control trial between emotional freedom techniques and AIT, and they are comparable. Where we're heading is doing a randomized control trial between AIT and EMDR, and then eventually shooting for a comparison between trauma-focused cognitive behavioral therapy and AIT to see if it's non-inferior. So thank you guys so much for taking time to watch this video. I hope it was helpful and it just piqued your interest a little bit. Happy to share the slide deck with Dr. Stapleton as well if you'd like to read more of any of the research that I cited. Thanks so much.